Hello, everyone. Welcome back to the WorkInHealth Foundation launch event. For those of you who are joining us now, welcome. Good morning. We now have a panel session just starting now on high-value care, moderated by Christina Åkerman. So just before I introduce the speakers and let Christina start the session, just a reminder, use the chat to introduce yourself to one another, get to know the other audience members, and use the questions tab to ask the panelists any questions during the session, and I will then redirect them at the end of the session. So Christina, the floor is now yours to introduce the session and the panelists.
Thank you very much, Claire. And let me start with an introduction to why the transformation to high-value care is important. In the current pandemic, it has become clear that being healthy is key, not only to the individual, but also for the resilience of the health systems, including avoiding burnout of staff in healthcare and making healthcare attractive work. But the truth is that it is challenging to achieve health, and we see healthcare costs escalating. The reason for this is not only an aging population, but that focus in healthcare is to a large extent on services delivered and processes followed, and not on the health outcomes that matter to patients, such as the ability to live normal and productive lives. One study from the US, for example, showed that only a bit more than 10% of mandatory measures to be reported in healthcare are actually health outcomes. And also most payment models focus on services delivered and not on the health outcomes. Furthermore, payment systems are mostly focused on paying for sick care and not for taking care of the health. The resources spent on disease prevention and on health promotion are only around 3 to 4% of the total health budgets in the OECD countries, while 75 to 80% of the budgets are spent on treating chronic conditions. And this lack of defining and measuring the health outcomes that matters to patients means that there is a lot of resources wasted in the system. An OECD report from 2017 suggests that at least 20% of health spending could be channeled towards better use. And the numbers show that many patients are unnecessarily harmed at the point of care because there are differences noticed in health outcomes that can't be explained by differences in patient characteristics, as well as many patients receiving unnecessary care that makes no difference to their health outcomes. And these issues we see are highly varied outcomes, and they are also, therefore, also preventable harm, but also inappropriate care and unnecessary spending. They have common root causes in the failure to define and measure health outcomes. And improvement potential is big. So therefore, we need to increase the focus on the patient. And the good news is that we do see an increasing interest from citizens and patients, of course supported by internet and digital technology, but an increasing interest in being much more involved in their own health. So we need to ask what matters to you, but also how are you? And have the patients report themselves to fully cover all relevant health outcomes. And these health outcomes are, as I've already pointed out, significantly underrepresented in available measures. I mentioned the study from US showing that only a bit more than 10% of mandatory measures to be reported in healthcare are health outcomes. And of those 10%, only 15% are reported by the patients themselves. So the question is then, does it really matter who reports? And the answer is yes. And let me take as an example on this, an example from the Swedish Cataract Registry. In a study of almost 10,000 patients, the vast majority, or 98% of those patients, they achieved improved vision on the test of the treatment. But 7% of those individuals, they at the same time reported being worse off in their daily activities than they were before treatment. So we had good clinical health outcomes, but poor patient-reported health outcomes. And when studying the result in further detail, it was found that these individuals with improved vision, but having new or greater difficulty with daily activities, they were often older individuals, and they spent most of their time reading, crafting, and doing other activities that depend on strong near vision. So the treatment had restored their long vision, but many of them had not received reading glasses to support near vision dependent activities. And as a result of that, their quality of life deteriorated following treatment. And this insight led to an improvement of the process, of course, in treatment of cataract, but also to a more informed discussion with the patient about their daily activities and how important the long vision is to the individual before the treatment was finally decided. And these type of informed discussions with the patients, they are key, as we are not aiming for more care, but for better health. So in summary, I would say to define, measure, and improve health outcomes that matter most to patients is the true north to restore healthcare to its purpose, which is health. And to support this transformation towards high-value care and health, EIT developed a handbook for pioneers, which was launched in spring last year, with a framework to support implementation and also with cases from organizations which had made substantial progress on their transformation journey. And as a next step to support the transformation, the EIT Health High Value Care Forum has been launched. The forum supports organizations to co-create transformation projects via bringing together citizens and patients, providers and payers, and life science industry, but also makes education and community building available to organizations. And today we are here at the launch of the WorkInHealth Foundation, discussing this much needed transformation to high value care, and more specifically, how to close the training gap in healthcare. So I am delighted to welcome to this roundtable 3 very experienced persons in transformation to high value care, all members of the EIT Health High Value Care Forum Advisory Board and representing patients and citizens, medical education and providers, and life sciences. And if I may start with Ania Henley. Ania, you are also an external advisor to EIT Health on citizen and patient engagement and involvement. You are a member of the board of EIT Health Ethical, Legal and Social Issues, as well as an advisor to Imperial in London on the Biomedical Research Centre Patient and Public Panel. So thanks for being in the studio, Ania, and joining the table. And let me ask you, to be able to transform to high-value care, it's evident that an early and active involvement of citizens and patients is crucial to understand the unmet need and to define the health outcomes that matter. So what, in your opinion, is the explanation to why this is so difficult still, and still that we do see such a significant waste of resources in healthcare spending or in health spending that I just have tried to discuss and cover here?
Look, we are, as mentioned before, in a patient-people-centered revolution at the moment. We've got the media, we've got internet, we've got apps, we've got digital health. I'm not going to name them all. We've got also, as you said, Christina, better communication between healthcare professionals and patients. People, once they have more knowledge, they will lobby for their needs. So, for example, if we look at something which happened very recently, the COP26, a lot of media and internet about the climate change, about recycling, saving energy, and now we have demonstration. In the 80s, you had the voices which became very powerful from HIV patients who actually demanded access. And this was everywhere in the US, in Europe. They demanded access to these experimental drugs that were being developed, and they really wanted them now. And I think the next step is really education, but education of all health stakeholders, not just the patients, not just the medics, everybody who is involved in a health innovation. Why is that? Because involving, engaging, and encouraging participation in clinical trials and living beds of patients, citizens throughout the innovation cycle. You've got unmet needs which are voiced. You have the health outcomes that matters to the people that those people that are their needs are met. So the logic is that satisfied patients satisfied patient will be more happy and healthy for a longer time. Therefore, I think it's better for them and a better impact to society. And this will reduce the waste of resources that you mentioned, Christina. I also think that if they help you develop health innovations, be it hospital services, be it technological, educational, apps, methodology actually of involvement to medical students, like I have done for many years at Imperial College, in Grenoble University, etc. This will reinforce the credibility of the innovation. So in my opinion, not involving patient and citizen is quite simply a waste of resources. And of course, with the pandemic, especially at the moment, all the countries are now facing financial difficulties. We have less staff, we have service overloads, etc. What we all know, and we need everyone to contribute. We need everyone to take responsibility, of course, if they can. Some people can't. And especially when it's about our taxes being spent. I mean, and to have enough money for old age, you need to invest money, don't you? So to ensure better and sustainable health for the old age, you need to invest in your health.
Thank you very much, Ania. And I heard you talking about involving throughout the innovation cycle as something which is very, very important. But you also mentioned, and maybe we haven't been that good at that yet, so that's why we still see this waste in the system. But you also talked about educate all stakeholders, and I would like you to come back to that a bit later. But before doing that, Ania, I leave you with that and thank you, and turn to Hazelzet, Professor Emeritus in Healthcare Quality and Outcome from Erasmus Medical Center in Rotterdam in the Netherlands, and also active in the Dutch Society for Personalized Care, as well as in the European University Hospital Alliance, which is an alliance dedicated to maximizing patient health outcomes. So thanks, welcome, John, and thanks for joining us from Rotterdam, I believe, this morning. And what, in your opinion, is the explanation for why medical school still teach these fundamentals that we have touched upon here? Ania was mentioning the involvement throughout the innovation cycle. We have talked about the high value care. These fundamentals, to such a limited extent. I know you have been very engaged, and you have probably seen progress made. But could you elaborate a bit on education and provider perspective, Jan, please?
Yes, good morning, Christina, and thank you for having me on this in this panel. Although I would have been rather in Paris now, but that's for another time. Yeah, sure, the education on medical faculties, you should be aware that a medical curriculum is built every 7 years. So it takes a lot of time before new items will be incorporated in a medical curriculum. And they need to compete with other topics as well. So that is difficult. And the content of the medical curriculum is determined by, most of the time, by older people, at least more experienced people, and it doesn't mean that they embrace this vision of more patient or person-centered care. So that's one. On the other hand, I see that there are changes now in the good direction. There is education developed both at medical student level, but certainly also at the level for starting physicians and nurses. And these two groups, so starting physicians and starting nurses, they are eager to learn new items. So that's a good one. The other last point is the fact that we still don't have enough educational material for this kind of education. So that's the reason why we try to develop it in collaboration with other hospitals or even with the IT help.
Thank
Just
you,
to start
Jan.
and answer your question.
Yeah, thank you, because you were also pointing at, if I got it right from you, cultural aspects, more or less, that we are not everyone putting together a curriculum in different medical professionals' education. They do not yet embrace this thinking, but you see a progress specifically in the generations to come. And you were also mentioning the need for education material to be brought forward, which is something I would also love to come back to when we will return, both of you, and discuss the WorkInHealth Foundation a bit more. So, but thank you, Jan, for this important input as well. And let me then move to our third panel participant, Thomas Allvin, Executive Director, Strategy and Healthcare Systems at the European Federation of Pharmaceutical Industries and Associations, the EFPIA, in Brussels. And Thomas, very welcome and thanks for joining us. And I would like you to start off in the direction of bringing together the healthcare and the life sciences, because what we use in healthcare is, of course, innovations from life sciences. And to define the unmet need and the health outcomes that matter most, these are important things to do, not only to the citizens and patients and healthcare providers, as discussed here, but also to create and sustain a healthy life science industry, because we have limited resources available, and it's central to reward innovation with the best health outcomes for patients and society. And despite knowing this, I still at least see existing silos between healthcare and industry. And what, in your opinion, is the explanation for this? Could you take this, Thomas, please?
Yes, thank you, Christina, and thanks very much for inviting me to this launch event. So I think there are probably a number of reasons, but maybe I think what's one of the most important reasons for this silo or this divide, as you explain it, is basically having this aligned understanding on what value is. Because I think when we talk about it here, it's might be self-evident for us what we talk about, but there are, as you know, many different understandings of value or what matters to patient, and this is not understood in the same way by all stakeholders or even by all countries or health systems. So obviously, I mean, the industry is adapting to the signals that we get from health systems, from payers, on what to invest in. So of course, the pharmaceutical industry, when we invest in research and development, that's a very long development process, around 10 years. So you need sort of stable signals to understand what does the health systems want, what kind of unmet needs are there, and what are we supposed to invest in. Of course, for medtech, it might be slightly shorter turnaround times, but the central principle is the same. So basically, what will be rewarded in the end? And I think we still have a situation where, if we look at Europe, different health systems, they have different processes for assessing innovation, how to value it, how to pay for it, how to introduce it in health systems, and they do this in different ways. And some of them not really looking at what matters to patients or the full concept of value sufficiently. So there you get a disconnect, which is why it's so important to have these kind of discussions. And I think, I mean, this is of course both about what you talked about, the outcomes that matter to patients. How do you define them, and are they valued by, for instance, HTA agencies, the payers? Are they looking at the patient perspective, patient satisfaction? Is that valued or not? But it's also, of course, of having, since high value care is about the outcomes you get in the long run versus the resource use in the long run over the patient pathway or the life cycle. Does a health system also look at this long-term perspective of resource use? As you said in the beginning, it's help to avoid unnecessary hospitalizations, been very important now during COVID. Or if you manage better chronic disease, you can help people stay healthy. They don't have to go to the emergency room or to the hospital, and that saves a lot of money in the long run. So do we look at that? Is that also valued? And how do we assess and how do we measure these things? And also comes back to the data. So I think one key component for closing this or bridging these silos is to have this aligned understanding of what value is, including what matters to people and to patients.
Thank you. And so to develop further, I would say then the assessments and define clearly what is valued, like you mentioned, long-term, the use of long-term resources, etc. And that probably also, Thomas, might need some education to really understand this better. Thank you very much. And let me then take up this discussion on education, because you have all in different ways, at least what I heard, touched upon this piece. And to start and go back to you, Jan, it seems there is a need from what you point at the culture perspective. You point at it takes time to develop a curriculum. It's about forward educational material, and you are very much engaged in the European University Hospital Alliance, where you are building like a community in building like a community in healthcare, I would say, to learn and to share best practices in order to reuse this waste and make health last in a way. So that we are today in the launch of the WorkInHealth Foundation. And what would your recommendation be to the WorkInHealth Foundation on how to support the reskilling needed, I would almost like to call it?
Yeah. Well, first of all, I think that to answer your question in 2 words, that is collaboration and sharing best practices. I think that healthcare is not developed to compete, but to collaborate. And high value care is not as straightforward like, for instance, the Krebs cycle in biochemistry. It's something which might be explained and might be in much different ways. It means sharing best practices is very important. And I have some experience with that, for instance, with the Dutch Federation of University Medical Centers, 7 hospitals working together, the Santion group, but also Linnaean. Linnaean is a group of about 1,000 people now, all working in healthcare, sharing their knowledge and their experience in high value care. And last but not least, you're mentioning it, I'm referring to the European University Hospital Alliance. And that's a very exciting collaboration between 9 hospitals. And originally, that was about four years ago, they said to a small working group, well, you should work on outcomes and care path, as if high value care was limited to just care path and outcome. Well, they are both very important, but it's just certainly not only those 2 things. And for me, high value care should be person-centered, value-driven, and sustainable. And on each of these topics, I think I could talk for an afternoon, but there's no time for that. But I specifically speak about person-centered and not patient-centered, because it's the interaction between the healthcare professional and the patient, which is very important. And that takes place in the consultation room, it takes place at the bedside, and nowadays it also takes place virtually online, but there is an interaction. And that interaction is important because that means two people with their own values. The patient values, the professional values, and that is the interaction which is important. So despite the fact that we are working on evidence-based medicine, it's the individual interpretation, looking at preferences and needs from the individual and values of the individual, which is important. It might be that an evidence-based medicine expression is going into direction A, but for this particular patient, it's more wise to decide on direction B. Well, value-driven is very obvious, looking at outcomes and experience that matter to patient versus the whole process, not only the resource, but also the process in which you use the resources. And the other one was the sustainability. And sustainability is something we always think on green, and that's important because we waste a lot of resources in healthcare, all kinds of plastics and material and etc. So that is very interesting to look at and to try to have a more green healthcare production. But on the other hand, it's also looking at the future and not just looking at 3 months after discharge of a patient. So the long-term result, and the long-term result might lead to a different choice, a different decision than when you just look at the short-term result. It also means looking at long-term contracts with payers. It also is looking at long-term relationships with life sciences, and not just selling or buying a box, but buying a kind of a solution instead of. And for all these things, you need different kinds of education. It's not common for a surgeon to talk about depression with a patient, but when you are measuring outcome, that means that at a certain stage, and you discuss the results of those questionnaires you use, or whatever kind of outcome you're measuring, it's the team who should decide, okay, this is a surgical patient, but there is a depression. I'm not trained, not skilled to discuss depression with a patient, but I should take care that it's happening by somebody else. Sustainability means also integrated care, and not just limited to the walls of a hospital or the walls of a clinic. It means working together across borders, across walls, and that is complicated. And you were asking me in the first question about education. I think nowadays, physicians and nurses are more trained to be a team player than to be an individual one who is deciding. And that makes a lot of a difference. So person-centered means also paying attention to the healthcare professional. And we're talking about working in health now, so that is very important. Sometimes it's even more important than directly go to the patient. Because if you have an exhausted healthcare professional, he or she cannot take care of the patient. If you take care of your healthcare professionals, or your physicians and nurses, and other people working in healthcare, then you can more easily go to patients. Okay, and sustainability is a different topic, which I would like to add. I stop here for a moment.
Thank you so much, Jan. And let us take what you said, person-centered, value-driven, and sustainable, as a summary so far moving forward, and then turn to Ania. And Ania, Jan was talking about person-centered, which of course includes both everyone, the citizens, it's the patients, it's the staff, it's about everyone being in that word. And from your end and knowing a lot about citizen and patient involvement and engagement, and that this is more or less a science in itself. It seems like there is a need for upskilling, I would say, in healthcare, to learn how to truly involve citizens and patients. I might be wrong, but please, what would your recommendation to the WorkInHealth Foundation be on how they can support this type of upskilling, as I try to call it?
Yeah, thanks for this question. It's actually very interesting because we all understand that without citizen and patient involvement, unmet needs will not be defined, and therefore outcome that matters won't be fulfilled. So involving citizen and patients throughout the innovation cycle, which is not that simple, but there are methodologies up there, you know, for CPs, for citizen and patient involvement and engagement. And this is how I think the foundation can really contribute, by working hand in hand with the public and the private sector. So to make this patient-centered revolution happen, as you know, as I spoke earlier of involving and engaging and participation in clinical trials of patients and citizens, let me explain I hope just quite shortly what is meant by involvement and engagement, which is a bit different within this innovation cycle. When we teach innovation cycle, we say that there are three main stages. You've got identify, you've got ideate, and you've got innovate. Within identifying, we're talking about social needs, identifying the social needs. There, if you involve the patient, you include those citizens in multidisciplinary teams, and you implicate them in the research and the scoping exercises. But if you're talking about engaging, it's a little bit different to create awareness. And for example, you have stalls, you have conferences in public places, such as community halls, for example, and that's actually an ideal venue to include unheard voices going out to the citizens. Then we have the second stage, which is ideate, which is about planning, about designing, about evaluating and granting. And this is where you can involve people to actually, within steering committees, you can involve them as mentors, as evaluators and jury members of those projects which are being developed. Whereas to engage is a little bit different again, and it's about you sort of getting citizen and patients to as speakers alongside the innovators, so working together in workshops, webinars on citizen patient involvement engagement, for example at EIT Health matchmaking events. Innovate is about implementing, assessing, and disseminating. So this is where a patient or a citizen can actually be involved in a sense in assessing your KPIs, in fact, assessing their own KPIs and how their involvement helped, but also about disseminating within their own associations, etc., patient associations. Engaging is co-hosting these sessions with, like EIT Health has done recently. I don't know if you followed this, Christina, at the European Patient Forum. EIT Health was actually co-hosting a session, and they were showcasing 2 EIT Health projects, which was really relevant, not only for the patients, but obviously for the Congress. So finally, just a word on participation, which is not the same as involving and engaging in our vocabulary that we try and teach, is participation is in clinical trials. It means basically what it says on the bottle. So it's about subjects to a clinical trial. So my recommendation to WorkInHealth Foundation would be to upskill all the members, every stakeholder, by educating them in the involvement and engagement of citizen and patient, but with the methodologies and resources already available, and work on new ones possibly.
Thank you, Ania. So that means using what's already out there, I hear you say, and really build that into the work, but also create new over time. And thank you very much, Ania. And going back to what Jan said on person-centered, value-driven, and sustainable, you were talking, Thomas, in the field of sustainability, I believe, when you were talking about how do we value the long-term resources as a payer and in procurement, etc. So I think there is a connection to this, because even if a brief look at public procurement shows an increasing interest in working together with the innovators to find solutions for the existing unmet needs, it seems like there is a need for skilling healthcare industry in further dismantling these silos to really secure the reward of innovation with the best health outcomes, as discussed, for patients and society. So based on that, your recommendation, I would love to hear that also for WorkInHealth on how to support this development.
Yes. So I mean, first, just to come back to that, what John said, because I think that's very true and important about, moving for, and I think that's where we're going, where we're moving from just selling a pill or selling a box with a product in it to a more kind of long-term partnership. And I think that the science and the innovation is pushing us in that direction anyway. And when you have now like these new kind of advanced cell and gene therapies, that is a completely different treatment paradigm. And so, if you move from treating, for instance, hemophilia through moving from intravenous injections every 3 to 7 days to one gene therapy that will hopefully repair the gene in the body, so the body can produce the blood clotting protein itself. Then you move to that model where it's about what kind of outcomes will we achieve in the long term, and of course you need to measure this. How long will this treatment effect? Will it be lifelong? Will it be for a year, 2 years, 10 years? And so we need to, and that takes a lot of upskilling, because you need to measure that data, and it's a completely different patient pathway and also with patient involvement. So I think we need to move in that direction. So I think the key here is to explore new types of partnership models for this kind of upskilling, because it needs all stakeholders on board. Of course, the industry is doing a lot of work on patient involvement in R&D, but also throughout the life cycle, and we have adopted principles and white papers on how to work with patient and patient groups. But of course, we need to broaden this. We have this new public-private partnership coming up, the Innovative Health Initiative, which will take over the old Innovative Medicines Initiative, but now involving also MedTech Digital, so co-funded by the life science sectors and the European Commission. And of course, this is one platform, but to use to set up this kind of public-private partnership, and also explore what's the role of the life science industry in this type of lifelong learning. How do you create the right ethical framework for that to happen, etc. So I think that would be important, and it's both about, as you talked about, patient involvement and engagement, but also about the data, the digital tools, the digital upskilling. And high value care is a lot about, it's driven by real-time data, how to use these outcomes data for sort of a learning process, and where you learn which practices work best. And of course, this can require new skills from all stakeholders.
Thank you very much, Thomas. So
we have quite a few questions from the audience, Christina.
Yes, I was going to say that, just finishing this and saying that thank you very much. I hear a lot of ideas here, and thank you very much, all of you. And let us now turn to the audience, Claire, for questions, if there
Thank
are
you. Yes,
any.
there are quite a lot. So I'll take the one with the most votes so far, which is from Carlotta. I think it might be one for you, Thomas. No matter what is being invested in, the patient should always be at the top of the list. Why does industry listen to payers for what to invest in instead of the needs of the patients? I think it echoes some of Ania's words.
A very good question, and I'm going to give a very maybe provocative but still straight answer. In health systems, the payers are between the industry and the patient. So if you if you leave aside, you know, over-the-counter medicines that you buy in the pharmacy, you buy headache pills. It's the payers who decide in the end what the patients will get. So they are the ones procuring the medicines. So if the payers don't pay for new innovation, it won't be bought, it won't be procured, and it won't reach the patient. So in most health systems in Europe, there are HTA agencies, so health technology assessment agencies, that assess new health technology. And, you know, is this medicine effective? Is it worth paying for? And so in this system, they are sort of the gatekeepers for medicines, but and also other health technologies. But this is why it's so important that the HTA agencies, when they do these assessments of what should the health system pay for, that they involve patients in their decision making, so that the patient perspective is accounted for. So I hope
Just
that
one
answers.
Do you allow me one quick comment? Because that's true for the HTAs, but that's a reactive way of looking at new drugs. While Ania was saying, the 3 steps in innovation start with identifying unmet needs, and that starts with the patient. But I think the patient should be involved much earlier in the direction to go for a new drug, and not to evaluate the new drug when it's already produced. Okay, just a comment.
Absolutely.
Thank you, Thomas. I think one for you, Ania, around co-creation with patients. It echoes what you said. It should start much sooner and last much longer than what is generally done today. Many are still lost in the area of patient engagement. So concretely, how do we make sure that patients are thought as an automatic resource in every study, every innovation project that comes along?
Well, it's a very good question, and I think it's an interesting one. It's certainly in England, for example, in the UK, if you get funding from the government, which, can I just say, funding from the government means our money, our taxes, you have to involve patients. You cannot get granting unless you show on your grant application how you're going to involve patients, how much the budget of it, how much it's going to cost you. You have to cost it. It's actually a real sort of science within the grant application. So to me, I think it should be part of, in a way, possibly a EU regulation that for granting, or for certainly EIT Health, for granting any money, and we are getting there with EIT Health, we need to make sure we have, for example, at EIT Health, we are building up now an assessment we have built up, and it's coming in the new business call next year, of an assessment which will help the people asking for money for their innovation to actually develop their involvement of patients, etc. So it'll help them to actually ask the right questions and what is needed. So yes, I think it should become automatic. I think it should be not a law, but it should come as an automatic thing. It has become the law in the UK, and I think it's a good idea if you get public funding.
Great. Thank you, Ania, sorry. Maybe one for you, Jan. It's about, it links to medical education. Do you see possible problems in the fact that we have new doctors who have grown in the digital world, while at the same time we have doctors who are less skilled with these new methods? Does this maybe pose a generation conflict that could affect the care and treatment of patients?
Well, yes, it could be. I think there could be also other generation conflicts, other topics. So I think those should be addressed. And I think that if there are older physicians who are not skilled to do these kind of digital consultation, they should be educated. And the other way around, I don't think you can exchange the complete face-to-face consultation with digital. So there should be a place for both. There is not a big problem there.
So digital education for the patients and the citizens.
Yeah.
Great. So I think this concludes the timing of the session. I don't know, Christina, if you have any concluding sentence or last words.
Yeah, just very brief and say that I think I hope that there was a lot of ideas coming up here on this person-centered, value-driven and sustainable words as the key here, relating to the importance of involving patients and citizens throughout the innovation cycle, and also the need for a lot of education on different existing methodology. But also I would like to add and stress what has been said here about the cultural shift that we also will have to address in this type of transformation to really reduce this existing waste and start defining, measuring, and improving health outcomes, and shift from sick care where we are today to healthcare. So that would be a brief summary of today's panel as far as I have seen here. And I would just like to end with thanking the audience, of course, the panel. Thank you very much for joining from different parts of Europe today. And congratulations to WorkInHealth for this launch. And maybe I should say bon appetit as well, Claire. It's lunchtime, isn't it?
My next line, Christina, thank you. Thank you to all of the panelists. Thank you very much, Thomas, Jan, Ania, and Christina. And for the audience, we now break for lunch or whatever you want to do in the break time. And the next panel session will start at 1:30, and it will be on the biomanufacturing skills gap. So bon appetit or good break.